Imagine this. You're an experienced surgeon. You're looking at an open tibial fracture, one of the most common severe injuries, really.
Hmm.
You're asked to classify it using a standard system, something you've done, well, countless times.
Yeah, standard practice.
Now imagine several of your equally experienced colleagues are doing the exact same thing for the very same fracture. How often do you think you'd all agree on the precise classification?
You'd hope pretty often, wouldn't you?
You would, wouldn't you? Maybe
Yeah.
90%, 100%. Well, astonishingly, research has shown that even among highly experienced orthopedic trauma surgeons, using a widely accepted standard system, agreement can be as low as 60%.
60%. That's quite low.
It really is. Think about that, like just classifying what the injury is, that presents a significant challenge. And that's just the starting point, before you even begin to figure out the absolute best way to treat it and definitively know if that treatment actually worked. Welcome to the Deep Dive. This is where we take a stack of source material, the articles, the research papers, the notes that you've shared with us, and we unpack the vital insights, the crucial nuggets of knowledge, really. We want to help you become truly well-informed on complex topics without, drowning in information overload.
A very common problem these days.
It is. Our mission today is to navigate the sometimes murky, always intricate waters of clinical research. We're going to embark on a deep dive focusing on how studies are designed, the fascinating and, yes, sometimes frustrating world of data analysis, and perhaps most crucially, how we actually measure whether a treatment has achieved a meaningful outcome, all with a particular eye on the challenges often seen within orthopedics.
A field with its own unique set of hurdles, certainly.
Exactly. It's about pulling out those essential pieces that make evaluating medical evidence less daunting and hopefully more insightful for you. And joining me today to guide us through this material is an expert with a remarkable ability to synthesize diverse information, to spot those subtle but critical patterns and, to connect the dots between the seemingly academic world of research methodology and its real-world implications for clinical practice, for informed decision-making.
Happy to be here and try to unravel some of it.
Great. He's here to help us understand not just what the studies say, but why it truly matters for the decisions you make. Right, let's jump straight in with a rapid-fire setup, just to preview some key angles of our deep dive. Thinking about professionals interpreting research, what, in your view, is the single most important concept they need to grasp right away?
The single most important. I'd have to say it's understanding the inherent limitations. Limitations imposed by the study design and the potential for bias. You see, every study has weaknesses. Recognizing where a particular study sits within the hierarchy of evidence, along with its specific risks of bias, that's the absolute cornerstone of responsible interpretation.
So you can't take it at face value?
Never. If you don't see the flaws, you can't truly trust the findings. It's fundamental.
All right, fundamental indeed. Next question. Why is the choice of how you measure results sometimes just as or even more critical than the treatment itself?
Oh, absolutely critical. Because if your outcome measure isn't truly meaningful, reliable, and valid, within the context of the study and for the patients involved, then whatever findings you report about the treatment's effect become highly questionable.
So you could get a significant result, but...
Exactly. You might see a statistically significant change in, say, a lab value, but if that doesn't translate into a tangible improvement in a patient's function or quality of life, what they actually care about, then the measure, and by extension the result, might lack clinical relevance. The measurements simply have to align with what matters.
What matters to the patient, ultimately.
Precisely.
Okay. And finally, stepping back from the statistics and the measurements for a moment, what's an ethical cornerstone of human research that simply cannot, under any circumstances, be overlooked?
Informed consent. It's the absolute bedrock principle. It demonstrates fundamental respect for participant autonomy, ensuring individuals fully comprehend the study's purpose, the methods, the potential risks and benefits, all the available alternatives, and confirming their decision to participate is truly voluntary, free from coercion, that is completely non-negotiable.
So even a perfectly designed study?
Without robust, genuine, informed consent, even the most methodologically brilliant study is built on ethically shaky ground. It's just unacceptable.
Powerful start. Thank you. Okay, let's unpack this in more detail then. We begin our deep dive into designing and analyzing studies with a concept that's often the first framework you encounter when trying to make sense of medical evidence: the hierarchy of evidence. What exactly is this, and why is it such a foundational tool?
Right. The hierarchy of evidence. It's essentially a structured way, a ranking system, really, for different types of study designs. It ranks them based on their inherent methodological quality, particularly in terms of their ability to minimize bias and, crucially, establish causality, especially when you're evaluating the effectiveness of interventions.
So it helps you judge reliability.
Exactly. It helps us as readers of research quickly gauge the relative reliability and trustworthiness of a study's findings compared to other types of studies. The version from the Oxford Center for Evidence-Based Medicine is one of the most widely used and recognized frameworks for this.
So it's like a pyramid or maybe a ladder with different study types at different levels. What sits at the very top when we're talking about individual studies looking at treatments?
Precisely. At the pinnacle, representing the highest level of primary evidence for therapeutic interventions, you typically find randomized controlled trials, RCTs. They're generally classified as level 1 evidence.
And why level 1? What makes them the top?
The reason they're placed there is fundamentally about their design's ability to reduce selection bias, which, as we said, is a major threat to validity. As you descend the hierarchy, you encounter other study designs. Controlled observational studies sit below RCTs, and their exact level can depend on factors like whether they collected data prospectively, looking forward in time, or retrospectively, looking back at existing data.
And lower down.
Further down still, you find study types with higher inherent risks of bias. Things like case series, uncontrolled studies, and finally, at the lowest level, typically level 5, you have things like expert opinion, anecdotal evidence, or studies based purely on mechanisms of action rather than actual clinical outcomes in patients.
Okay. You mentioned RCTs are the gold standard for primary evidence. What is it about that randomization process that makes them so powerful, especially against bias?
Well, the fundamental strength of an RCT lies in the random allocation of participants to different groups, typically the group receiving the new treatment, and a comparison or control group. The idea is that by randomizing, you ensure that, on average, the groups are comparable right at the start of the study.
Comparable in what way?
In terms of both known factors that might influence the outcome, like age, severity of disease, other health conditions, and, crucially, unknown factors that you might not even be aware of or be able to measure. This comparability means that if you observe a significant difference in outcomes between the groups at the end, you could be much more confident that the difference is due to the intervention being studied, rather than some pre-existing difference between the groups.
So it isolates the effect of the treatment itself.
It's the most robust way we have to try and establish that cause and effect relationship between a treatment and an outcome.
That logic holds for many medical fields, but the source material correctly points out that even this gold standard faces significant limitations, particularly in surgical disciplines like orthopedics. What are some of the practical logistical hurdles there?
Ah, yes. The reality of applying RCTs to surgery is challenging, to say the least. They are notoriously difficult and often prohibitively expensive to organize and run. They involve a substantial workload for the research team, often over a very long duration, which can lead to logistical nightmares and real challenges in just completing the study as planned.
And beyond just the cost and time.
Beyond the practicalities, there are profound difficulties with recruitment. Both surgeons and patients can struggle with the concept of randomization. A surgeon might have a strong clinical preference for one technique over another based on their experience, right? And randomization removes their autonomy to choose what they feel is best for that patient.
And the patient.
Similarly, a patient might have heard about a new technique and specifically want that one. Or they might simply be unwilling to accept the possibility of being randomized to an older or perhaps less preferred method, or even a non-surgical option, if that's part of the comparison. This resistance from both sides can severely impede recruitment and make surgical RCTs incredibly hard to complete successfully. And this brings us directly to a really critical ethical principle: clinical equipoise. This isn't just academic jargon. It's absolutely fundamental to the ethics of randomizing patients in the first place.
Okay, clinical equipoise. How does that tie into justifying randomization ethically? What does it mean?
Clinical equipoise means there must be genuine uncertainty within the expert medical community, including the investigators conducting the study, about whether one arm of the experiment is definitively superior to another.
So if doctors already think one treatment is better.
Exactly. If there is already a clear consensus based on existing evidence that one treatment is better or safer than another, it would generally be considered unethical to randomize patients to the treatment believed to be inferior. Equipoise is the necessary ethical precondition. It allows researchers to justify subjecting patients to the potential risks of an experimental treatment, or randomizing them away from a potentially beneficial treatment precisely because the best course of action is genuinely unknown.
So if the investigator thinks they know the answer,
If you, as the investigator, truly believe one treatment is superior, you have an ethical obligation to provide that treatment, not randomize patients away from it. Establishing and maintaining that state of genuine uncertainty equipoise throughout the trial is absolutely vital.
Right, and the source material mentions a particularly challenging application of this principle in orthopedics. Sham surgeries. That sounds ethically complex just from the name.
It is indeed, and it highlights that ethical tension beautifully. Sham surgeries are essentially the surgical equivalent of a placebo in a drug trial. They involve performing part of a surgical procedure, or perhaps a procedure that mimics the experience, but crucially omitting the actual therapeutic step.
Like making the cut but not doing the repair.
Exactly. Making incisions, perhaps, but not performing the repair or the decompression you're studying. The scientific rationale is powerful. They allow for a truly blinded comparison because neither the patient nor the assessing clinician knows whether the full procedure was actually performed. This helps to isolate the true effect of the surgical intervention itself from the placebo effect, the psychological impact of simply having undergone any procedure.
But the
ethical tension is undeniable. You're performing an invasive, non-therapeutic procedure that carries risks, anesthesia risks, infection, nerve damage potentially, on a patient who may, as a result, be denied an effective treatment by being in that sham group. Now, current literature and ethical guidelines do suggest that sham surgeries can have a place in research, but only under very stringent conditions.
What sort of conditions?
These include strict adherence to that principle of clinical equipoise. Genuine uncertainty about efficacy is paramount. Rigorous informed consent, where the patient fully understands they might receive a sham procedure, is absolutely essential. And there needs to be very careful consideration of the risks versus the potential benefits of gaining definitive knowledge from the trial. It's a very sensitive area, but sometimes it's considered necessary to truly determine if a surgical intervention works beyond just the placebo effect and the natural history of the condition.
Fascinating, and it definitely highlights the complexities researchers face. So beyond these primary studies like RCTs, we also rely heavily on secondary and filtered research, things like systematic reviews and meta-analyses. The hierarchy of evidence traditionally places these above individual studies, even RCTs. Why is that the case?
Yes, they are often positioned at the top because they represent a synthesis or a summary of the best available primary evidence on a specific clinical question. A systematic review is a rigorous process. It involves a comprehensive and ideally unbiased search for all relevant primary studies addressing a particular question, followed by a critical appraisal and synthesis of their findings.
So it aims to be exhaustive and transparent.
Exactly. The aim is to reduce bias in the review process itself by being transparent about the search strategy, the inclusion criteria, the quality assessment, and how the results were combined. A meta-analysis takes this a step further. If the studies included in a systematic review are sufficiently similar in terms of their populations, interventions, outcome measures, that sort of thing, requiring a degree of homogeneity, then a meta-analysis can statistically pool the quantitative data from these studies.
And the benefit of pooling the data?
It increases the sample size and the statistical power. This potentially allows researchers to detect smaller effects or provide a much more precise estimate of the treatment effect than any single study could on its own.
And when pooling those statistics in a meta-analysis, the source mentions fixed effects versus random effects models. What's the key difference in what those models assume about the data?
Yes, that comes down to what the model assumes about the underlying effect size across the included studies. A fixed effects model, something like the Mantel-Haenszel method, assumes there is one true single effect size for the intervention across all the populations represented in the included studies. It assumes any variation in results seen between the studies is purely due to random chance, sampling error. It essentially calculates a weighted average, giving more weight to larger studies.
Okay, and random effects.
In contrast, a random effects model, like the Dersimonian and Laird method, is generally considered more conservative and, frankly, often more realistic in clinical research. It assumes that the true effect size might actually vary to some degree from study to study, not just because of random chance, but also because of actual differences in the populations studied, perhaps the way the intervention was applied, the settings, and so on. It accounts for this between-study heterogeneity in addition to the within-study random variation.
So if the studies are quite different.
If there's significant heterogeneity in the results of the included studies, a random effects model is usually more appropriate, and it will typically produce wider confidence intervals, reflecting the greater uncertainty due to this underlying variation between studies.
So, systematic reviews and meta-analyses sound like powerful tools for summarizing evidence. But the source material also presents important criticisms, suggesting they are, well, only as good as the studies they include. What are the main caveats we should be aware of when reading them?
This is an absolutely crucial point, and it really underpins that adage you mentioned. Secondary evidence is only as strong as the studies that comprise it. A beautifully conducted systematic review, meticulously done, can still yield misleading conclusions if the primary studies it includes are methodologically flawed, have high risks of bias, or are simply not relevant to current practice.
So, pooling bad studies doesn't make the result good.
Precisely. Including non-randomized studies when good RCTs exist, pooling data from studies with vastly different patient populations or interventions, or including studies that are technically sound but clinically irrelevant to the question at hand. All these things can compromise the validity and the practical impact of the review or meta-analysis. Just because you've pooled a lot of data doesn't automatically mean the answer is right or useful. If you're pooling weak evidence, you might just get a more precise estimate of the wrong answer. Readers really need to look critically at the methods section of any systematic review, understand how the studies were identified, how their quality was assessed, and whether it was genuinely appropriate to pool their results statistically in a meta-analysis, given the potential for heterogeneity.
That brings us right back to the concept of bias, which you highlighted at the start as being so fundamental. You mentioned selection bias as particularly important in study design. Could you elaborate on that and maybe give a few more examples of where it can creep in, potentially distorting findings even early on?
Certainly. Bias, remember, is a systematic error. It's not random noise. It's a consistent slant in the study design or conduct that leads to results that are consistently different from the true effect. Selection bias, as we discussed, arises when there are systematic differences in the characteristics of the groups being compared before the intervention even happens. This can happen if participants aren't recruited or allocated to groups in a truly random or comparable way.
So, beyond just using historical controls, which you said is always bad.
Yes, using historical controls is almost always problematic due to changes over time in care, diagnosis, everything. But selection bias can occur much more subtly. For example, if a study is conducted only at a highly specialized tertiary referral center, the patients recruited there might have more complex or severe forms of the condition than the average patient you'd see in a general hospital with that same condition. Comparing outcomes in this highly selected group to outcomes reported elsewhere could introduce selection bias. Similarly, if the method of recruiting patients differs between groups, perhaps one group is recruited from an outpatient clinic and another from an inpatient ward, you might inadvertently select patients with different levels of mobility or overall health status. Even in an RCT, if the process of randomization isn't properly concealed, meaning the researchers enrolling patients know or can guess which group the next patient will be assigned to, they might consciously or unconsciously steer certain types of patients into one group over the other based on prognostic factors. That undermines the whole point of randomization and reintroduces selection bias.
And the sources mention other types of bias too.
Yes, absolutely. Detection bias, for instance. This occurs when the outcome is assessed differently between the groups. If the assessors, the people measuring the outcome, are aware of which treatment group a patient received, their expectations might influence their assessment. Blinding the assessors to the treatment group is the key way to mitigate this. Then there's reporting bias, which refers to the selective reporting of findings. For example, only publishing results that are statistically significant or favorable to a particular treatment, while suppressing negative or null findings. This seriously distorts the overall evidence landscape, making treatments look better than they perhaps are.
That reporting bias sounds particularly concerning, especially when we think about the pressure to publish. The source material calls out p-hacking as an unethical practice linked to this. What exactly is p-hacking, and why is it considered so damaging to the integrity of research?
P-hacking is a really problematic form of data manipulation. It's often driven by that intense pressure researchers feel to find statistically significant results, typically that p-value below 0.05, because significant results are generally easier to publish. It's not usually outright fabrication of data, but it involves playing with the data or the analysis methods after the data have been collected, specifically until a desired p-value is achieved.
How might someone do that?
Examples include running multiple different statistical tests on the same dataset and only reporting the one that happens to yield a significant result. Or perhaps collecting more data points if the initial analysis isn't significant, and then rerunning the analysis until it crosses the threshold. Selectively excluding outlier data points that might dilute the effect is another way. Or measuring many different outcomes, but only reporting the few that happen to show a significant difference by chance.
And why is that so bad? It sounds like just exploring the data.
The reason p-hacking is so damaging and considered unethical is that it fundamentally violates the logic of hypothesis testing and the p-value itself. The p-value is the probability of observing your data, or more extreme data, assuming the null hypothesis is true, and, crucially, assuming the test and analysis plan were decided upon before you saw the data. When you p-hack, you're essentially searching through the data until you find any pattern that looks significant just by chance, and then you report it as if it were the primary finding you set out to discover all along.
So it inflates the false positive rate.
Massively. It hugely inflates the chance of reporting false positive results, finding an effect that isn't really there. It misleads other researchers, clinicians, and ultimately patients about the true state of evidence. It's a distortion of reality driven by chasing a specific statistical outcome, and it severely undermines the trustworthiness of the research process.
Absolutely. It's a stark reminder that transparency and ethical conduct are just as important as getting the statistics right. Speaking of statistics, let's delve into some foundational concepts that are essential for interpreting the number studies report, starting with the basic distinction between samples and populations.
Right. In research, we're almost always interested in understanding something about a large group, the population. They could be all patients with a certain type of fracture, all people undergoing a specific type of surgery, or maybe all adults in a country. However, it's rarely feasible or even possible to study every single member of that population. So instead, we study a smaller, hopefully representative subset, and that's our sample.
And the goal is to generalize from the sample.
Exactly. The goal of research is to use the data we collect from our sample to make inferences or generalized conclusions back to the larger population from which it was drawn. This is why how you select your sample is so critically important, going right back to that issue of selection bias. Random sampling, where every member of the population theoretically has an equal chance of being included, is the ideal because it helps ensure the sample is representative of the population, making your inferences more reliable. When we describe our sample data, we often use descriptive statistics. Data can be continuous, meaning it can take any value within a range, like height or blood pressure, or it can be categorical, meaning it falls into distinct categories, like sex, blood type, or fracture grade. For continuous data, the average is a common way to describe the center of the data. The sources also mention variance, which is a measure of dispersion. It tells you how spread out the individual data points are around that mean.
How is variance calculated?
It's calculated as the average of the squared differences of each data point from the mean. Measures of dispersion like variance and its square root, the standard deviation, are crucial because just knowing the average isn't enough. You really need to know how much the data varies around that average.
And how do these concepts then lead us into hypothesis testing?
Hypothesis testing is the formal process researchers use to determine if the results observed in their sample provide enough evidence to support a conclusion about the wider population. It typically involves setting up two competing statements: the null hypothesis, often written as H, and the alternative hypothesis, H or sometimes H.
What do those usually state?
The null hypothesis usually states there is no effect or no difference between the groups being compared. For example, the new treatment has no effect on healing time compared to the old one. The alternative hypothesis states that there is an effect or a difference. For example, the new treatment does improve healing time. We then perform a statistical test on our sample data to see how likely it is we'd observe results like ours if the null hypothesis were actually true in the population.
Okay, and this is where the famous p-value comes in, the number that often gets so much attention. We often hear researchers chasing that magic p.05, but what does the p-value actually represent?
Yes. This is probably one of the most commonly misunderstood concepts in statistics, and it's absolutely vital to get it right. The p-value is the probability of observing data from your sample that is as extreme as or more extreme than what you actually measured, assuming that the null hypothesis is true.
Can you give an example?
Okay, so if you conduct a study comparing two treatments and you get a p-value of, say, 0.03, it means that if there were truly no difference between those treatments in the entire population, if the null hypothesis were correct, you would still expect to see a difference as large as or larger than the one you observed in your sample only 3% of the time, just due to random chance or sampling variability. That traditional threshold of zero point zero 0.05 or 5% for statistical significance is largely arbitrary. It's a convention that arose historically. If your p-value is less than this threshold, you typically reject the null hypothesis and conclude that your results provide statistically significant evidence against the null hypothesis and therefore in favor of your alternative hypothesis.
But what is the p-value not?
Crucially, it's absolutely critical to understand what the p-value is not. It is not the probability that the null hypothesis is true. It is not the probability that you are wrong if you reject the null hypothesis, although it's related to that concept. And, very importantly, it tells you absolutely nothing directly about the size or the clinical importance of the observed effect. As the source notes, a small p-value indicates that your observed data are unlikely if the null hypothesis is true, so it provides evidence against the null. You can think of it as a sort of currency for statistical robustness. Smaller p-values mean stronger evidence from the specific sample against the null. But even a very low p-value, say 0.001, means there's still a 0.1% chance of seeing results that extreme if the null were true. In some contexts, like drug safety, even a 1% chance, p0.01, of being wrong about a harmful effect could be catastrophic if applied to a large population.
So necessary but not sufficient.
Exactly. Statistical significance is often a necessary condition for claiming an effect, but it's rarely sufficient on its own to make clinical decisions.
You mentioned that many statistical tests compare groups by looking at their variances. Could you give us a simplified view of how that works?
Yes, many common tests, particularly those comparing the means of different groups, are fundamentally based on analyzing variance. A key concept here is partitioning variance. Take ANOVA, for instance, analysis of variance, which is used when you're comparing the means of 3 or more groups. ANOVA essentially breaks down the total variation you see in the data into different sources.
What sources?
Primarily, the variation between the groups, which might be due to the treatment effect you're interested in, and the variation within each group, which is generally considered due to random error and individual differences among participants in the same group. It then compares the magnitude of the variance between the groups relative to the variance within the groups. This comparison is often done using something called the F-statistic, which follows a specific statistical distribution called the F-distribution. Fundamentally, it's a ratio of 2 variances.
And if the variance between groups is large?
If the variance between groups is significantly larger than the variance within groups, the test concludes there's a statistically significant difference somewhere among the group means. It's about seeing if the groups are more different from each other than individuals tend to be within their own group.
Okay. So p-values give us a sense of statistical significance of the likelihood of results being due to chance if the null hypothesis is true. But the source material strongly advocates looking beyond the p-value, especially at confidence intervals or CIs. Why are CIs so vital, perhaps even more so than the p-value, for interpreting clinical relevance?
Confidence intervals are absolutely critical for moving beyond just that binary significant or not significant decision to understand the potential magnitude and the precision of the treatment effect, and therefore its clinical meaningfulness. A confidence interval, most commonly a 95% CI, provides a range of values within which the true effect size in the larger population is likely to lie, based on the results observed in your sample. It gives you a sense of the uncertainty around your estimate of the effect.
So it gives a range, not just a single number or a yes-no. How do we interpret that range?
The key to interpreting a CI lies in where that range falls, relative to 2 important points. 0, if you're looking at a difference between groups, 0 means no difference. And critically, relative to what is considered a clinically important difference. That's the minimum change that patients or clinicians would consider meaningful and worthwhile in practice. Let's maybe walk through a few scenarios to make it clear. If your 95% CI for the difference between 2 treatments does not include 0, that aligns with a statistically significant result, typically p0.05. The entire range suggests a difference likely exists, but then you must look at where that range lies. If the entire CI, both the lower and upper bounds, is above what you've defined as a clinically important difference, then you can be more confident that the treatment not only has a statistically significant effect, but also one that is likely to be clinically worthwhile.
Okay, what if it does include 0?
If the CI includes 0, your result is not statistically significant, typically pp.05. This means your data don't provide enough evidence to reject the null hypothesis of no difference. The true effect could plausibly be 0, or it could even point in the opposite direction if the CI spans both negative and positive values. This outcome is essentially uncertain based on your data.
Right. And what about situations where it's significant but maybe not clinically meaningful, or vice versa?
Exactly. Consider a scenario where the p-value is, say, 0.06, just missing that conventional zero point zero 0.05 cutoff, so not statistically significant. The 95 per CCI for the difference between groups might be, for example, negative 1.5 plus 8.5 points on a pain scale, where you've decided a clinically important difference is 5 points. Now, the CI includes 0, consistent with p.05, but look at the upper end. It includes values like 8.5, which are well above your clinically important threshold of 5.
So it could be important.
It suggests that while your study didn't find statistically significant evidence against the null, the results are still compatible with a clinically important benefit. You might conclude your study was perhaps underpowered to detect this difference definitively, or the result remains uncertain, but you certainly can't confidently say the treatment is ineffective based on that CI. Now flip that. Consider a study with a p-value of 0.04 statistically significant, but the 95% CI for the effect size is, say, plus 0.5, plus 2.5 points on that same pain scale, where 5 points is the clinically important difference. Here, the CI does not include 0, it's statistically significant, but the entire range, even the upper limit of 2.5, is well below the 5-point threshold you decided was clinically important.
So significant, but maybe not worth it.
Precisely. You have a statistically significant result, but the CI strongly suggests that the true effect, while likely existing, is probably too small to be clinically meaningful for patients. Or, one last scenario. Imagine a study where the p-value is high, say a 0.20, clearly not significant, and the CI for the effect is, say, negative 3 plus 1.5. This CI includes 0, consistent with a non-significant p-value. And importantly, the upper limit of the plausible effect, 1.5, is well below your clinically important difference. In this case, both the p-value and the CI point towards the treatment likely being ineffective in any clinically meaningful way.
So the CI gives much more context.
Absolutely. The CI gives you not just a yes-no about statistical significance, but a range of plausible values for the actual effect size. This allows you to judge the precision of the estimate. A wide CI means less precision, more uncertainty. A narrow CI means more precision, and, crucially, to directly assess its clinical relevance in a way the p-value alone simply cannot. Always look at the CI.
That was a really clear explanation, thank you. A deep dive into how studies are designed and the statistical language we really need to understand to interpret them properly. That transitions us perfectly into our next segment. The critical challenges of measuring what truly matters in clinical outcomes and the fundamental ethical standards that have to underpin all human research. You highlighted earlier that choosing the right outcome measure is paramount. Let's expand a bit on the different domains of outcomes and why that choice is so vital.
Right. Outcomes in healthcare are multifaceted, aren't they? We can think about them in several broad domains. There are clinical outcomes, which relate directly to the patient's health status and the biological or functional effects of the intervention. Things like pain levels, range of motion, maybe fracture healing time on an X-ray, presence of infection, or even mortality.
So the direct health impact.
Yes. Then there are process of care outcomes, which look more at how care is delivered, things like length of hospital stay, readmission rates, resource utilization. Patient satisfaction is another crucial domain, though it's important to note it's often distinct from clinical outcomes. And finally, there are economic outcomes, focusing on costs, both the direct costs of the treatment itself and perhaps indirect costs, like lost productivity for the patient. Selecting the correct outcome measure, or perhaps measures, for a particular study is absolutely critical because it must align with the research question being asked and be meaningful within the context of the intervention being studied and the patient population involved. If you're studying a surgery designed to reduce pain and improve function, measuring only, say, an inflammatory marker in the blood might be scientifically interesting, but it's unlikely to be clinically relevant on its own.
And this links to the idea of value in healthcare.
Very much so. This is becoming even more prominent with the shift we're seeing toward value-based healthcare models, moving away from simply paying for the volume of services provided to paying for the value delivered. And value is often defined, quite simply, as the outcomes achieved relative to the costs incurred to achieve them. If you can't accurately and meaningfully measure the outcomes that genuinely matter to patients and to the healthcare system, you simply can't demonstrate value. So the measure must capture what the intervention is intended to change, and that change must be relevant either to the patient's life or to the efficiency of the healthcare system.
Okay, so assuming we know what we want to measure, what properties define a good outcome measure, what should we be looking for when a study reports using a particular scale or test?
The two most fundamental properties you need to look for are reliability and validity. Think of reliability as consistency or repeatability. A reliable instrument produces the same result, or very similar results, when measuring the same stable phenomenon under the same conditions.
But measurements aren't always perfect.
Never. Measurement always includes some degree of error. Whether that's error introduced by the person taking the measurement, we call that radar error, or error from the instrument itself, perhaps it's not calibrated properly. There's also random fluctuation or variability in the patient's state, even over short periods. Reliability is concerned with how much of the observed variation in measurements is due to these errors versus how much reflects the true underlying change in the thing you're actually trying to measure.
Are there different types of reliability?
Yes, several. Inter-rater reliability refers to the degree of agreement between two or more different observers or clinicians measuring the same thing. Inter-rater reliability is the consistency of measurements taken by the same observer on different occasions. When assessing reliability, we talk about concepts like agreement, concordance, repeatability, essentially. How consistent is the measurement?
Okay, so that's reliability, consistency. What about validity?
Validity, on the other hand, is about accuracy. It's the degree to which an instrument truly measures what it is intended to measure. It answers the fundamental question: are we actually measuring the concept we think we are measuring? The source makes a very important point here. Validity dictates what you are able to do with the test results. If a measure is valid, you can confidently use its results to make decisions or draw conclusions about the specific construct it measures, like knee function or pain level.
And reliability is needed for validity.
Critically, yes. A measure that is inaccurate or unreliable cannot be valid. If you're not getting consistent results when you repeat the measurement, low reliability, you certainly can't be accurately measuring the true underlying state, validity. Think about it. If your bathroom scale gives you wildly different readings every time you step on it, it's unreliable, and therefore it's not a valid measure of your true weight. Establishing validity is often more challenging than reliability and involves accumulating evidence from various sources, things like content validity, does it cover all aspects of the concept? Construct validity, does it relate to other measures as expected? Criterion validity, does it correlate with the gold standard? To show the measure behaves in ways consistent with the theoretical concept it's supposed to capture.
Right. Let's explore some of the different measurement types then, starting with patient-reported outcome measures, or PROMs, which seem increasingly prominent in clinical research, particularly orthopedics.
Indeed, they are. PROMs are standardized, validated questionnaires that are completed directly by patients themselves. They are specifically designed to capture the patient's own perspective on their health status, their functional limitations, their symptoms like pain or stiffness, and their overall well-being or quality of life.
And why the shift towards using these more?
Well, the rise of PROMs really reflects a growing recognition that the patient's experience and their functional status are often the most important outcomes, particularly in areas like orthopedics, where improving quality of life, reducing pain, and restoring function are frequently the primary goals of treatment. They provide a more holistic picture that clinician-based measures or imaging alone might completely miss. The sources list several common examples, many specific to musculoskeletal health. Things like simple visual analog scales, VAS, or numeric rating scales for pain are very common. Then you have condition-specific scores like the Oxford Hip Score or Oxford Knee Score, the International Knee Documentation Committee, IKDC, subjective form, which is widely used for knee function, the Hip Disability and Osteoarthritis Outcome Score, HOS, the Western Ontario and McMaster University's Osteoarthritis Index, the WOMAX, for hip and knee osteoarthritis symptoms and function. For upper limb problems, there's the Disabilities of the Arm, Shoulder, and Hand, the ASHA questionnaire. The Marks Activity Level Score is another example, specifically assessing how physically active a patient is.
And what makes a good PROM beyond reliability and validity?
Desirable properties also include acceptability to patients. Are the questions understandable? Is it too burdensome or long to complete? Feasibility in practice is also key. How much time does it take to administer and score? The Health Assessment Questionnaire, HAQ for instance, is noted as being relatively fast, while something like the SF-36, a widely used general health status measure, can vary quite a bit in completion time depending on how it's administered on paper, online, or via an interview. It's also really important to distinguish PROMs, which measure health outcomes, from patient-reported experience measures, or PREMs. PREMs measure aspects of the care process itself, things like communication with staff, cleanliness of the facilities, waiting times, not the health outcome. And as the source points out, studies have generally shown quite a weak association between PREMs and PROMs, meaning a patient can report a poor experience of care but still have a good clinical outcome. or vice versa. They capture fundamentally different things.
Okay, that clarifies PROMs. And then we have the measures taken by clinicians or observers. What are some examples there, and what are the particular challenges associated with those?
Right, these are the more traditional objective or perhaps semi-objective measures performed by healthcare professionals. Common examples in orthopedics include goniometry to measure joint range of motion. Now, while using a goniometer is generally considered more reliable than just visual estimation, it still has limitations, especially for small joints, and the measurement technique used is absolutely crucial for consistency. Radiographic measurement of angles and alignments is often the most accurate, but of course is limited by radiation exposure and isn't practical for frequent follow-up. Muscle power is very commonly assessed using the Medical Research Council, MRC, grading system from M0, no contraction, up to M5, normal power against full resistance. This is widely used, but can have subjective elements, particularly when distinguishing between grades M4, movement against gravity with some resistance, and M5, normal. Sensory tests, like two-point discrimination to assess nerve function, require really careful technique. Applying too much pressure, for instance, can give inaccurate results.
Grip strength measurement needs standardization. Usually multiple attempts are taken, and whether you report the mean or the best result depends on the protocol. And crucially, the dynamometer, the instrument itself, needs regular calibration to ensure its accuracy.
And what about classification systems? You mentioned the issue with tibial fracture classification right at the start.
Yes, that's a significant challenge, particularly relevant to the example you used. Classification systems are used everywhere in orthopedics to categorize the severity or type of injuries or conditions. We have the AO classification for fractures, Schatzker for tibial plateau fractures, Gustillo and Anderson for open fractures, Churn for assessing soft tissue injury around closed fractures. While these systems provide a necessary framework for communication and research, their reliability, particularly that inter-observer reliability, the agreement between different clinicians looking at the same case can be surprisingly low.
Like that 60% figure.
Exactly. That 60% agreement rate among experienced orthopedic trauma surgeons classifying open tibial fractures using the standard Gustillo and Anderson system is a stark reminder. Even with defined criteria, subjective interpretation can lead to considerable disagreement. And if different surgeons classify the same injury differently, how can you consistently use that classification either as a baseline characteristic to ensure groups are comparable, or even as an outcome measure in research? It introduces significant measurement error and reduces the study's power and credibility. Other observer-based measures mentioned include trauma severity scores like TRIS, which combine physiological data like blood pressure and anatomical injury data to predict survival after major trauma. Cosmesis, or the aesthetic appearance, is another important outcome, particularly in specialties like plastic surgery or pediatric orthopedics, for instance, after limb lengthening procedures. Measuring cosmesis is often subjective and can be controversial, despite its undeniable psychosocial implications for patients. There's a recognized need for validated cosmetic outcome measures, which are feasible to develop using things like standardized photography and scoring systems. For infections like osteomyelitis, classification systems exist. The source mentions Waldvogel's system, which is more descriptive compared to May's system, which is designed more to guide treatment and predict prognosis. And finally, cost-utility analysis using outcomes like quality-adjusted life years, or QLYs, is a critical economic outcome measure. A QAY combines the length of life gained with a measure of its quality, often derived from patient utility scores based on questionnaires like the EQ5D. It's highly relevant in orthopedics because improving quality of life is often the primary benefit of many interventions, and 2LYs allow comparison of the cost-effectiveness of interventions across different areas of healthcare.
That provides a really comprehensive overview of the measurement challenges. Let's transition now to the equally critical foundation of ethical practice in human research. The source material outlines several key pillars, starting with informed consent. We touched on it in the rapid fire, but let's delve deeper into what constitutes truly informed consent.
Informed consent is, without any exaggeration, non-negotiable. It's the primary ethical principle that upholds the autonomy, the self-determination of potential research participants. For consent to be truly informed, the participant must be provided with all relevant information about the study. This includes its purpose, the study procedures, what exactly will happen to them, how often for how long, any potential risks, both common and rare, serious and non-serious. Potential benefits, both perhaps directly to them, but also importantly to future patients, or scientific knowledge. What are the alternative treatments or procedures available outside the study? What are their rights as a participant, including the absolute right to withdraw at any time without penalty? and information about confidentiality and how their data will be handled and protected.
So it's not just giving them a leaflet.
Absolutely not. It's not enough just to provide the information, perhaps in a lengthy document. The participant must also understand it. This often involves the researcher checking their comprehension, maybe asking them to explain key aspects of the study back in their own words. And crucially, their decision to participate must be entirely voluntary, free from any coercion or undue influence. This voluntary aspect can be particularly challenging in situations where there is a significant power imbalance, perhaps, between a physician and their patient, a professor and their student, or an employer and employee. The consent process should really be an ongoing conversation, not just a one-off signature on a form.
And the source mentions there are specific populations considered vulnerable who require additional protections in research.
Yes, absolutely. Certain groups are deemed vulnerable because various factors such as compromised autonomy, cognitive limitations, being institutionalized, or facing unequal power dynamics may affect their ability to give truly free and informed consent, or might make them more susceptible to coercion or exploitation. These groups are afforded extra safeguards in research regulations.
Who falls into these categories?
Examples typically include minors, children under the legal age of consent, adults with impaired mental capacity who would require proxy consent from a legally authorized representative, pregnant women, fetuses, and neonates due to the potential risks to the developing child, and prisoners due to the constraints on their liberty and potential for coercion within the institutional setting. For children, specific rules apply, often including the need for ongoing permission or assent from the child themselves, depending on their age and maturity level, in addition to permission from their parents or legal guardians. There are also very strict conditions under which parental permission might be waived, such as in certain emergency research settings, but these are tightly regulated and reviewed.
Okay. Another critical ethical consideration highlighted is conflicts of interest. These seem particularly prevalent, or at least discussed more often, in research with industry ties. What constitutes a conflict, and why are they problematic for research integrity?
A conflict of interest arises when a person's primary professional duty, and in research, that's primarily upholding the integrity of the study and protecting the welfare of the participants, could be improperly influenced by a secondary interest. This secondary interest is very often financial, but it could also be non-financial things like seeking academic promotion, gaining professional recognition, or even just a strong personal belief in the value of one's own work or invention. In industry-funded research, you often have at least three parties involved: the researcher, their institution, like a university or hospital, and the funding corporation. Each party has its own interests, which may not always perfectly align. The corporation naturally wants the research to show their product is effective and safe. The institution might benefit financially from research grants or intellectual property rights. The researcher might gain funding for their lab, publications which help their career, and perhaps personal financial benefits like consultancy fees or royalties.
And the problem is the potential for bias.
Yes, exactly. Financial conflicts of interest are a major concern because there's a considerable body of evidence suggesting they can subtly, or sometimes even overtly, bias the research process and its outcomes. For example, a researcher receiving significant royalties from an implant they helped develop might, consciously or unconsciously, be biased towards designing studies or interpreting results in a way that favors that implant. Professional bodies like the AAOS, American Academy of Orthopedic Surgeons, mentioned in the source, often have principles recommending stringent measures to manage these conflicts. These might include things like avoiding trading stocks in the funding company during the trial, and having research on one's own royalty-generating products conducted by an independent, disinterested third party if possible. The evidence base, as noted in the source, does suggest a correlation. Clinical trials with significant industry funding or author ties are statistically more likely to report results favorable to the industry sponsor compared to independently funded trials.
Now, this doesn't automatically mean all industry-funded research is biased, but it certainly highlights the inherent risk and the absolute need for transparency and robust management strategies for these conflicts. Full disclosure is the minimum standard.
It certainly seems many of these ethical principles we take for granted now were solidified in response to some quite shocking past abuses in research. The source material provides some sobering historical examples.
Yes. Tragically, many of the current ethical regulations and oversight mechanisms we have are direct responses to egregious historical violations of ethical principles. The Tuskegee syphilis experiment, which ran for decades in the U.S., is perhaps the most infamous example. African American men with syphilis were deliberately denied effective treatment penicillin long after it became widely available, purely so researchers could study the natural progression of the untreated disease. Participants were actively deceived and profoundly harmed. The Stanford Prison Experiment, though different in nature and smaller scale, highlighted the ethical failure of researchers to adequately protect participants and to stop the study when individuals were clearly experiencing severe psychological distress and felt unable to withdraw. And then there was Project MKUltra, involving CIA-sponsored experiments, often conducted on unwitting human subjects, using drugs and psychological manipulation techniques in the mid-20th century.
And these led to real changes in oversight.
Absolutely. Public outcry and subsequent investigations into these and other abuses led to significant reforms. In the U.S., the National Research Act of 1974 was a landmark piece of legislation. It established the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. This commission produced the pivotal Belmont Report, which outlined the 3 core ethical principles that now guide human research: respect for persons, autonomy and protection of the vulnerable, beneficence, do no harm, maximize benefits, and justice, fair distribution of burdens and benefits. This eventually led to the development of the Common Rule, which is the set of federal regulations governing most research involving human subjects in the U.S. It mandates things like institutional review boards, IRBs, or ethics committees, IECs, to review and approve research protocols before they begin, requires detailed, informed written consent, and sets out specific requirements for risk-benefit assessments and ensuring subject rights and welfare are protected. Internationally, guidelines like the International Council for Harmonization, ICH, Good Clinical Practice, GCP, provide a unified standard for ensuring the quality, integrity, and ethical conduct of clinical trials involving human participants globally. These historical lessons are absolutely vital reminders of why these protections are so necessary and must be rigorously upheld.
So with all these layers of design, analysis, measurement, and ethics, who ultimately bears the responsibility for ensuring a study is conducted properly and ethically on the ground?
The primary responsibility falls squarely on the shoulders of the principal investigator, or PI. This is the individual, usually a clinician or senior researcher, who leads the research team at a particular study site. The PI is accountable for the overall conduct of the study at their site and, critically, for protecting the rights, safety, and welfare of the research subjects under their care. They are the one ultimately answerable to the sponsor, the ethics committee, and regulatory authorities for what happens at their site.
What are some of the key responsibilities of a PI, particularly under guidelines like GCP?
Under GCP, the PI has a wide range of specific responsibilities. They must ensure that the study is conducted strictly in compliance with the ethically approved protocol, those core ethical principles we discussed, like informed consent, and all relevant local and international regulatory requirements. If any deviation from the protocol is necessary, for example, if a patient's immediate safety requires a different clinical action, the PI must document it thoroughly and report it appropriately. Importantly, any significant changes or amendments to the protocol generally require prior review and approval from the Ethics Committee, IRB-IEC, before they're implemented. The exception is if a deviation is immediately necessary to eliminate an unforeseen hazard to a participant. In that case, it should be done, but then documented and reported to the Ethics Committee and sponsor immediately afterwards. The PI is also responsible for ensuring subjects are kept adequately informed throughout the study and obtaining reconsent if significant new information about risks or potential benefits emerges, or if there are major changes to the study protocol that might affect their willingness to continue. They must also ensure the accuracy, completeness, and integrity of all the study data collected at their site.
You mentioned recruitment earlier as being a major challenge, particularly for RCTs. How does that impact the PI specifically, and what are some common issues they might face in just managing the day-to-day trial operations?
Yes, poor recruitment and participant retention is, unfortunately, one of the most common reasons why clinical trials fail to meet their objectives or sometimes even fail to complete at all. The PI needs to be realistic when predicting recruitment rates for their site during the planning phase. They need to identify potential factors that might hinder enrollment. Maybe the protocol is extremely complex with lots of visits, perhaps the eligibility criteria are very strict, or maybe patients in their locality just aren't interested in the specific comparison being made. They need to regularly review recruitment progress against the targets. If it's lagging behind, the PI needs to proactively discuss the difficulties with their research staff and the trial sponsor. Solutions might involve providing additional training or resources to staff, looking at ways to simplify aspects of the protocol if feasible, which would need ethics approval, collaborating with other sites, or perhaps requesting an extension to the recruitment period if resources allow. It requires active management. Managing the overall trial operations involves significant risk management as well. Essential documents like the detailed protocol itself, standard operating procedures, SOPs, for various tasks like data entry or sample handling, the monitoring plan from the sponsor, and all the ethics committee approvals must be meticulously organized and in place before the very first subject is enrolled. Regulatory audits or inspections often uncover common findings. Things like inadequate monitoring by the sponsor, instances of PI non-compliance with the protocol or regulations, deficiencies in the informed consent process or documentation, and issues with accountability for the investigational product, like ensuring the correct drug or device is stored, dispensed, used, and tracked properly. A diligent PI and their research team need to be proactive in identifying and mitigating these potential risks, and ready to implement swift corrective and preventive actions if any issues are identified during monitoring or audits.
Right, so assuming the trial runs successfully, all the data are collected and analyzed. The findings then need to be communicated, typically through writing a research manuscript for publication. The source discusses the standard IMRAD structure. Can you quickly break down what should ideally go into each of those sections for clarity?
Yes, IMRAD. It stands for Introduction, Methods, Results, and Discussion. It's the universally accepted structure for most original scientific research manuscripts because it provides a logical and predictable flow. It allows readers to quickly understand why the study was done, introduction, how it was done, methods, what was found, results, and what those findings mean, discussion.
So starting with the introduction.
The introduction sets the stage. It should provide the necessary background context for the research, explain the existing knowledge gap or the clinical problem the study addresses, clearly state the specific research question or hypothesis being tested, and finish by presenting the study's primary aim or objective.
Then the method sounds crucial for judging quality.
The method section is absolutely critical for transparency and reproducibility. It needs to describe exactly how the study was conducted in sufficient detail that another researcher could, at least in theory, replicate it. This includes detailing the study design, for example, RCT, cohort study, the setting where it took place, the participant selection criteria, inclusion and exclusion, and how participants were recruited. It needs to describe the interventions or exposures being studied, define the primary and secondary outcome measures used, and exactly how they were assessed. Information about the sample size calculation and the statistical methods used for the analysis must also be included here. Crucially, the description of the study sample itself, demographics, baseline characteristics of the participants, often presented in Table 1, belongs in the methods section, not the results.
Okay, the results, just the facts.
The results section should present the findings objectively, without interpretation or speculation at this stage. You report the data, often using tables and figures for clarity. You should include key descriptive statistics like means, standard deviations, medians, ranges, and the results of your inferential statistical tests, making sure to include the numerical values for effect sizes, like mean differences or odds ratios, their confidence intervals, and the exact p-values. If you use the word significant in a statistical context, it absolutely must be followed by the corresponding p-value or CI to justify that claim. You should focus on reporting the main findings that directly relate to your primary study objectives, especially if space is limited.
And finally, the discussion is where you interpret it all.
Exactly. The discussion section is where you interpret your results and place them in the broader context. You typically start by briefly summarizing your study's most important findings, answering the research question you post in the introduction. Then you compare and contrast your results with previous research in the field. Do your findings support, contradict, or perhaps add nuance to what was already known? You should discuss the clinical relevance or implications of your findings. What do they mean for patient care, clinical practice, or perhaps health policy? And this is absolutely vital for trustworthiness and scientific integrity. You must explicitly discuss your study's limitations. No study is perfect. Honestly acknowledging the limitations, perhaps potential biases that couldn't be fully controlled, issues with measurement tools, constraints imposed by the sample size or duration, or factors affecting the generalizability of your findings significantly increases the credibility of your work. Discussing limitations also often helps to identify remaining uncertainties and generate important ideas for future research.
And using reporting guidelines helps with this.
Yes, adhering to specific reporting guidelines, like the PRISMA statement for systematic reviews and meta-analyses, or CONSORT for RCTs, helps ensure that all the essential information is included in a standardized way, which improves the quality and transparency of reporting. The whole submission process to a journal involves gathering all these materials, including increasingly detailed disclosures of any potential financial conflicts of interest from all authors, again, to promote transparency.
That was a really thorough breakdown of the entire research journey, from initial design right through to publication. Let's maybe transition into a quick lightning round just to reinforce a few of the key concepts we've discussed. All right, lightning round time. Beyond the p-value, what is one specific statistical concept that professionals should always pay close attention to when they're reading research papers?
Confidence intervals. Always look at the range of the plausible effect and, crucially, how that range relates to what you consider clinically important, not just whether it happens to cross zero or not.
Good one. Okay, if you're reading a paper and something feels a bit off, or maybe too good to be true, what's a potential red flag that might suggest reporting bias, or maybe even p-hacking could be involved?
Watch out for selective reporting. For instance, if lots of different outcomes were measured according to the methods section, but only one or two are highlighted as significant in the results section without mentioning the others, or perhaps a lack of transparency about exactly how the statistical analyses were conducted, especially if the results seem unexpectedly strong or clean.
Makes sense. And for someone perhaps new to research ethics or wanting a refresher, where is a key place they could start looking for foundational information on the ethical standards for human studies?
Well, searching for resources on the U.S. Common Rule, especially if working with U.S. federally funded research, is a good starting point there. Or, for broader international guidance that's widely adopted, looking up the ICH Good Clinical Practice GCP guidelines would be an excellent place to begin. They cover ethical conduct and data quality.
Excellent, great quick recap. So, pulling all of this together now, thinking about our listeners trying to navigate this complex world, what are the key actionable takeaways they should really keep in mind when they're trying to evaluate clinical research findings for themselves?
Okay, key takeaways. First, I'd say use the hierarchy of evidence as a useful starting guide, but always remember its limitations. Really try to understand the inherent strengths and weaknesses of the specific study design you're looking at. RCTs are theoretically strong against bias, but hard to do well, especially in surgery. Systematic reviews pool evidence, but remember, they're only ever as good as the primary studies they include. Be critical of the design itself. Second, scrutinize how the outcomes were measured. Was a patient reported using a validated PROM? Was it clinician observed using a potentially less reliable classification system? Understand the importance of demonstrated reliability and validity for those specific measures used in that study. Critically ask, does the measure actually capture what truly matters in clinical practice or, more importantly, to the patient? Third, be constantly vigilant for potential biases and underlying ethical considerations. Look for subtle signs of selection bias in how participants were recruited or allocated to groups. Think about potential reporting bias and how the results are presented. Are they telling the whole story? And always consider whether potential conflicts of interest, especially financial ones, might plausibly influence the interpretation or conclusions drawn by the authors. Fourth, make sure you go beyond the p-value. While statistical significance tells you something about the likelihood of the results being due purely to chance under the null hypothesis, always use the confidence interval. Use it to understand the potential magnitude and the precision of the treatment effect, and then use that information to gauge its actual clinical relevance or importance. And finally, I'd say look for transparency and honesty in the reporting itself. Does the paper follow a standard logical structure like IMRAD? Do the authors openly and frankly discuss their study's limitations? Acknowledging limitations isn't a sign of weakness, it's actually a sign of rigorous, trustworthy research, and it helps you understand where the evidence is still uncertain or where more research is needed.
Those are incredibly valuable filters, I think, for anyone to apply when they're trying to sift through the, frankly, overwhelming amount of medical literature out there. Thank you so much for guiding us through this really detailed deep dive into clinical research design, analysis, outcome measurement, and all those crucial ethical considerations.
It's been my pleasure. It is a complex area, but as you say, it's absolutely vital for anyone involved in healthcare, whether researcher, clinician, or even patient, to have a basic grasp of these principles.
Absolutely. And if you found this deep dive into evaluating clinical research valuable, perhaps consider sharing it with a colleague who might also benefit, or leaving us a rating wherever you happen to get your podcasts. It genuinely helps other professionals find the show. So the next time you pick up a research paper, maybe don't just look for that headline p-value or the simple conclusion in the abstract. Ask yourself, what did they really measure here? And can I actually trust that measurement? And perhaps more importantly, what does that confidence interval really tell me about whether this finding actually matters for my patient or for my practice? That question, I think, is often much harder to answer than just looking at the statistics alone, but it's infinitely more important in the long run. That's all for this deep dive. Join us next time as we unpack another complex topic.